Okay, I think we'll make a start. Good afternoon, everybody. I was just waiting till I could see our two presenters had joined, and both of them thankfully joined now, which is great. So Rachel and Josie are both here. So first of all, very warm welcome to our final event of our RIC Learning Week. This is the 5th of 5 sessions that we've had this week, entitled Leading with Evidence, What Works in Tackling Inequalities. So just to introduce myself, I'm Duncan Cooper. I'm a public health professional. I work in the Reducing Inequalities Alliance in Bradford District and Craven Partnership. So it's my pleasure to be able to host this afternoon. So just to tell you what's going to happen today, as I say, our theme is about leading with evidence. The Bradford Institute for the Bradford Inequalities Research Unit. Sorry, let's get it right. Josie Dixon and Rachel Moss are going to present on some of the work that they've been doing in helping doing some overall evaluation of the individual and total projects that are going on with our reducing inequalities in communities. For those of you that don't know much about the RIC programme, I know some of you will have heard me already say this 3 times, but I'm sorry, there might be a few people that have joined for the first time today. But the Reducing Inequalities in Communities programme, RIC, was set up in 2019 with some additional funding that we received to reduce inequalities in Central Bradford. So that was the Central Bradford CCG at the time. Because the inequalities are so stark, there's a 20-year difference in healthy life expectancy, and because that is so multifaceted in terms of the factors that cause and lead to that, we commissioned 20 different programmes using a life course approach. So there's all sorts of things going on with children, older adults that are ending their life, and then obviously working age adults as well. So Josie and Rachel are just going to feedback today on the approach to evaluation, some of the detailed results as well from evaluating the impact of those programmes. So that's just to give you a bit of background. And before we end as well, we'll have a few words from Dr. Sahel Abbas, who's overseen the programme from the start, given that this is our last of our 5 RIC programmes today. So that's what's going to happen. I've got a few little things just to go through very quickly to do with housekeeping. So put your name in the chat, that would be great, just so everybody knows who you are, because sometimes different things appear on the screen. Please put yourself on mute unless you're presenting or asking questions. We do get sounds of people washing up and shutting the door and all sorts of things coming in. So please put yourself on mute. We're recording this session, so if you don't want to be on camera for any reason, just turn your camera off. That's absolutely fine. And there will be an opportunity to ask questions at the end, but by all means put them in the chat as we go along. Me and Sophie will make a note of those, and hopefully we'll have enough time to get back to ask Josie and Rachel all about that at the end. So we're probably hoping to have about 15 minutes at the end, Josie and Rachel, just to get a few questions in and a bit of a wrapping up session. And if anybody is moved to tweet as we go along or go on social media with some of this stuff, our hashtag is Reducing Inequalities BDC, all one word. So feel free to tweet as you go along as well. So I think that's it. We'll come up with some questions at the end, pop them in the chat. And I will hand over now back to Sophie, who I believe is driving the slides for us.
Yeah, it looks like Josie's got them covered, which is probably easier.
Oh, Josie, you're doing it great.
Can you see them okay? Is it in normal? Is it just in presentation mode or?
No, we can see. Yeah, we can see them well, and we can actually see you at the bottom, which is quite nice as well.
Oh, this is all new to me. Okay. Well, if anything goes wrong with the slides, then please let me know. So yeah, we were going to talk you through kind of the work that we've done as a part of RIC, really, about how we increase the evidence base with the real focus of trying to tackle the inequalities that are happening within Bradford. I'm going to do a lot of the what we did, and then Rachel's going to come in with some really nice examples as we go through of the different types of research that we've done and how that's helped us with this work. See how I move on with the slide now. Has that worked?
Yeah.
This is really weird. It's like I'm hovering in some weird PowerPoint land anyway, isn't it? Right, so I'll stop wittering on and I'll just talk now. So way back when, and actually still now, this is a slide that I think Sahel shared first off, and it's looking at sort of public health and medical interventions and how much science effectiveness evidence there is of commonly used treatments. And it's pretty shocking to say that most of what we do is based on best intentions, but there's very, very limited numbers of interventions and treatments that are actually evidence-based. So how did I do that last time? Okay. And I think that some of this, there we go. Some of this is really to do with, in the historically anyway, there's a real mismatch between research and practice. So you have researchers on one side using a sort of a top-down approach where they'll do a really strong clinical trial or a randomized controlled trial in really sort of protected settings with research-ready people and participants, and come up with interventions that are effective, but in a kind of ivory tower setting. And on the other hand, you have all of public health and the voluntary sector delivering things that are relevant to the communities they're working with, they're acceptable and deliverable in practice, and with the best intentions but lacking strong evidence of their effectiveness. And it just gives a really incomplete picture for commissioning decisions, and it's hard to know what to do for the best and how well it's working. So what we often see is on the left-hand side, the frequency of using of evidence in commissioning tends to be around what they think works best, what they know works on the ground, what the case studies, the stories from the people that have received the interventions are, and rarely are they from sort of really strong, rigorous, evidence-based evaluations. So what we wanted to do was to bridge that gap, really, and we've been doing this within BIRU Bradford for a while. We've been trying to evaluate things in practice rather than just kind of out in our own research world, ivory towers. So trying to integrate practice and research into one. It does feel challenging at times. I think everybody who's been involved in RIC, if they remember the early days, will know that it did at times feel a little bit like we were asking for Mission Impossible. But I think through the learning that we had working with Better Start Bradford, so we started working on evaluating interventions in practice there back in 2015. And obviously with Rick being really engaged and really on board with trying this new way to build up the evidence, and us having our partners, obviously within BIRU Bradford, we understand Bradford and our partners, but with some additional expertise from Queen Mary's in London and University of York, and actually with a very strong data set that we have in Connected Bradford, we were able to do something that wasn't a mission impossible, and nothing is impossible, especially if there's cheese involved. Not just me, I'm sure. So for an intervention to be effective, I think whenever we start working with partners, they just say, well, we just want to know if it works. Does it work? But actually, there's really 3 key ingredients to an effective intervention in practice. And it's that they reach and engage those that need it the most, because if it doesn't, it's going to increase inequalities, not decrease them. It needs to be able to be delivered with fidelity, so you can be confident that you're able to deliver an intervention as it was designed to be, to make sure that it has the impact that it needs to have. And then at that point, we can start to look and see if it makes a key difference to outcomes of those that need it. And to do that, we need evidence from research and from practice. So when we started working with Rick, we developed our sort of evidence rating scales. Now, this was adapted from one that the Early Intervention Foundation used for their evidence ratings. But right at the start, you have an intervention that's delivered, but it's got no theory of change, which is sort of explaining how and why it should make a difference, and a logic model, which is basically a summary of why it would make a difference. Up to sort of looking to see around level 3 that it actually works in practice, it's acceptable, it can be delivered. And then we start to nudge up the evidence of does it work? But it's a slow process. It's not something that we can just do really quickly or overnight. And that's why nudging it up is the right way to go about it. We also use our BIRU Bradford evaluation framework, which, as I mentioned earlier, is about how things work to evaluate in practice. And it's thinking at all times around the community engagement of what communities need and what's important to them. It's about what's important to the key stakeholders and what their timelines and priorities are. You can't see what's at the bottom there, but it's also around the local context of what's happening. And then within that, we do our implementation evaluation, which is looking at whether it can be delivered, our before and after, which is evidence of promise, and then effectiveness, which is where it becomes very complicated, and you do definitely need more of a sort of a research partner to be doing that, and some really good data as well. So the way I like to try and describe how we evaluate in practice and how we build our evidence base is to think of it of like building a house, and unless you get the foundations right, it's not going to be a very, very sturdy place to live, or anywhere you would want to live, actually. So the first thing that we really need to do is understand the needs of the community and of the partners, as I said, within that evaluation model. We need to make sure that we're delivering things that the community are ready to engage in, and we also need to know how it will work. So this is where I'm going to hand over to Rachel to tell us a little bit about some of the work that we did about understanding need within the RIC community. Rachel, I don't know how I'm going to change my face on here. No,
I just suddenly thought, I can't get my face on there, but apologies. Hopefully you can still hear me. Josie, as long as you look interested, hopefully it'll all be fine. Fab, thank you for letting me know you can hear me. That's great. So one example, as Josie's mentioned, of the way in which we explored how we can understand more about the community, we utilised the community readiness model. So kind of in a nutshell, that is really, the model is an existing model that's been created by researchers, and it's really to understand how ready is a community to engage with a particular topic or a particular intervention. In our case, in this instance, we explored end-of-life care. So we wanted to ascertain to what degree are individuals in the community, specifically South Asian individuals, to what degree are they ready to engage with end-of-life care services? Oh, it's just gone. Josie, I think the slides, oh, it's back. There we go. Sorry. Apologies. That's all right. And we identified that using this model, that individuals, South Asian individuals in the community were at the pre-planning stage in terms of their readiness to engage with this particular area, i.e. services to help support them at end of life. However, we found that the readiness of the healthcare system was limited. And quite a nice kind of infographic you'll see on the right-hand side of this slide is the model states there are 9 stages of community readiness. So at the bottom, there's no awareness, and then right up to the top, there's community at kind of stage 9, community ownership. So the community has ownership of the area or area of focus or concern. So as you can see here, as indicated by the blue arrow, we identified that the South Asian community were at the pre-planning stage. So they were kind of almost ready to engage. They had kind of above vague awareness, but this model can help you understand ways in which you can try and improve a community's readiness to engage with an area. Thank you, Josie. Oh, it's gone again.
I don't know what, I really do apologise, everybody. We've done this enough times, but I'd never been in this
spot
before. There we go.
There we go. Yeah, so again, in terms of understanding need, it can be important to use data to help you understand the need of a particular community. So one kind of, in terms of looking at RIC and the levels of smoking in pregnancy of women in RIC, it was identified really that it wasn't a particular area of concern. However, when you kind of do a deep data dive to really ascertain the values and the figures, here you can see that actually there are certain different ethnic differences between the smoking rates in pregnancy. So as you can see here, that's circled on the left-hand side, 45% of white British mums in pregnancy were found to be smoking, as well as those that were white and from Central Eastern European countries, that's 42%, whereas those individuals of Pakistani heritage had rates of smoking in pregnancy at 5%. So this actually shows that although kind of perhaps, you know, broadly speaking, perhaps there isn't an area of concern, but actually when we look at the specific data, we can see that there are ethnic differences here. So this deep data dive, bit of a mouthful, it helps us understand that actually as well, although there are low rates of smoking in pregnancy, that 5% of women that are of Pakistani heritage, Pakistani heritage women have a relatively high risk of moderate exposure to carbon monoxide that's potentially due to secondhand smoking. So again, although the rates are low in this particular group, understanding more about the data can give you a more kind of a more whole-based approach to understand what's actually going on. Thank you, Josie.
Thanks, Rachel. So once we have the need that we understand, our next level is getting the right building blocks to address those needs, really. So it's thinking about designing the intervention that is going to work in that community, in that local context, and really around developing a logic model that understands what you're going to do and what that is going to lead to in terms of outcomes and outputs. And then making sure that you're collecting and capturing the right data to be able to demonstrate that you've done what you set out to do. So logic models are an absolute key part of everything we do. I think anyone who's worked with it may have shared that sense of horror at the thought of being forced to do a logic model and what on earth it is. But really, I think hopefully now people will tell you that they see the value in it. And it's really, the way I like to see it is a bit like an ingredients list of a recipe. So it's what you need. And who you need to do it, what you're going to do, where and how you're going to do that, and what you expect to happen as a consequence of that. So it's really just like logically setting out your plans, and then from that you can show what you're going to get at the end of it. But the real value of doing a logic model, by the way, you can have a much more eloquent 5-minute video on a logic model on our website. There's one on theory of change, one on logic models, and it's a really clear and straightforward overview of what they are. I didn't want to go into too much detail here. But what it does enable, oh, sorry, I thought there was another slide based on that. No. And what it does enable is for you to think about, you know, what you need, and if things aren't quite working, you can look at what element of that you might need to change and tinker with it and then review it again. So it gives you a way to sort of test and learn and demonstrate how things are working, and actually sometimes if they're not, how we can address that. So yeah, every single one of the RIC interventions has been nudged up the evidence rating scale just by getting to the point where they can explain how and why their interventions will work. And then the next element of that really is about cementing all of those bricks together. So moving up to level 3, where we can look at an implementation evaluation that's based on the logic model to say, is this doing what it says it would? We can look at how then, if it's not doing what we said it would, how we can change and adapt to improve that delivery. And we can also make sure that participants and staff feel that this is the right intervention, that it's acceptable to them, and check for that the right communities are engaged and engaging in the projects. I was just going to flag that in terms of our Bourne and Bradford evaluation framework, this is the first step really in the evaluation of, but one of the most important, because you can have the world's most effective intervention, but if it's not going to engage the community you're working with or is impossible to deliver, then it's pointless. So it's a really crucial element of what we do. So evidence of implementation success would involve producing an implementation report which kind of goes through each of the elements of the logic model. So evidence that it's acceptable, that it's been delivered with fidelity, that it's reached and recruited and retained the right people in the project. And you can learn about key barriers and facilitators and adapt as you go to improve things. So I think now I'm going to hand back to Rachel, who's, oh no, this is the bit that I was talking about, which is you can start to see then where things may or may not be working. So if you don't get the outcome you wanted, you don't just come to the general assumption that the intervention doesn't work. It might be that something's not being delivered quite in the right way, whether it's, you know, the number of staffing or the actual activities that are underway. It might be that there's a block in recruitment, or where are you getting referrals from, or the location that you're delivering it in that's not quite working, or it might be something about access of people getting there. So you can look at each individual element and make sure that everything is as it should be, and only at that point then would you think, well, maybe this isn't the right intervention, then it's not working in the way we thought it would. But it gives you the opportunity to really look in detail and see what's happening. And this is another great success for the RIC intervention. So the vast majority of them achieved level 3. There were a couple that weren't able to implement successfully and that ended up not being recommissioned. But that's a really important value as well, because if something isn't working and it's not the right use of money, then it needs to be reviewed. And this gives you a good sort of strong base on which to make your decisions on that element. So this is where Rachel's going to come in and talk through an example of an implementation evaluation that worked really well within RIC.
Thank you. So here we've got the Young People Social Prescribing Pilot. So this was a non-medical intervention that was aiming to reduce the need for young people to try to make return visits to their GP or to access CAMS, which is support for their mental health. So over the period, they received 177 referrals over 2 years, and they found that out of that 177 referrals, they had 105 young people that engaged with their service, which is really good. The referral routes, they had 24 different types of organisations, and they had young people from 10 out of 12 of the PCN areas, which again showing that it's having the reach that it intended. Yeah, I think that's it for that slide. Thank you.
So once you've demonstrated the evidence that it can work in practice, the next step is to move from level 3 to 4, which I like to think of actually it's time to start moving in and testing out the house that you've just built. And it's thinking about, is it making a difference to those who do take part in the intervention? Again, we would see this as the second element of the evaluation. So it's thinking about things like a before and after evaluation. So it's looking for evidence of promise. So there's no sort of real concrete causal rigorous evaluation with control groups that can tell you for sure that the intervention is making a difference, but you can look at how things are improving from the beginning to the end of the project, and that will give you a real sense of evidence of promise, as I said, that the intervention is making a difference. And types of evidence that can show this would be a before and after study, where you might see positive trends in an outcome. But importantly for this, it's using validated questionnaires, so things that have been tested to make sure that they can detect a difference over time. And qualitative studies can be really good here as well. So you can really start to understand what families or what staff who've been delivering the programme really see as the sort of the key components or the value, or to understand where there might be any sort of barriers to making a big difference. I'm going to hand back to Rachel, who's going to talk through the co-located welfare benefits as a good example of this.
Thank you, Josie. So this is an example to show where a study was kind of, I suppose we're showing it here as an example of an implementation study. So this study was aiming to try and provide welfare benefit support to individuals within the community. So they worked with providers in order to test the acceptability of using these particular assessments, kind of surveys, at the start and at the end of the intervention. So measures on financial security, mental health and physical health were given at the start and at the end of the intervention, so before an individual received support as well as afterwards. And it was identified that 125 people, so that's 69% of the total sample, completed it before and after surveys. So this helps show that these surveys are acceptable to the individuals that are engaging in this particular study. the results, the data shows that there was significant improvement in wellbeing scores and that there was significant improvement in self-reported quality of life. So this really shows that it had a positive impact on individuals' kind of well-being after receiving this level of support. Thank you.
So then our final steps are, once we've moved in, it's kind of testing out the house and how well it works sort of longer term, and keep us dry and warm. So we're thinking about moving from level 4 to 5, which is causal evidence of effectiveness and cost benefits as well. So this is where, as I mentioned at the beginning, where it gets a little bit more complex, and you probably would want a research partner to be supporting with you this. And it's where you would need really strong levels of evidence. So we're looking at the effectiveness evaluations here, where you would need big data, so you need quite a large sample size, but importantly, you'd also need a control sample of very similar people, but who have not had the intervention, and that enables us to think that actually if there's any differences in the outcomes for those that have and haven't had the intervention, then we can attribute that to the intervention and say that it has a causal effect on the outcome, and that gives us really strong evidence that it is working and it will make a difference, and it's probably then likely to be cost beneficial as well to services. And as I mentioned, the data that we're able to use in Bradford is through the Connected Bradford data set, which we can provide you links to or tell you more about if you're interested, and the Born in Bradford data, which is relevant for children and families across the district in Bradford. And I said the types of evidence that will show us a causal effect are, our standard is a randomised controlled trial where you randomly allocate people to an intervention or not. But in real life, where things are being delivered as part of practice, it's very difficult to set up a randomised controlled trial, and often it's not even ethical. Systematic reviews are where you would look at a number of different studies that are then building up a picture of how strong the evidence is for a particular intervention. And the one that we've used within RIC is what we call quasi-experimental studies, and that's where you would get a matched group of controls. We call them pseudo because they're not randomized, but they're as good as we can get. So they're very similarly matched, but they've not had the intervention that we're interested in. And I'm going to pass back to Rachel, who's going to go through 2 examples of this within RIC.
Thank you. So here we've got one example, which is known as CLICS, was the CLICS service, or Central Locality Integrated Care Service. So this intervention was focusing on trying to integrate social prescribing into general practice. So for those that don't know, social prescribing helps identify services, groups, and other elements of support for individuals to help them kind of improve or meet their practical, physical, and emotional needs. So the aim of our evaluation was to use Connected Bradford to create, as Josie mentioned, a pseudo control group. And then we compared, using this data, we compared unplanned hospital admissions for those who have received CLICS and those who hadn't received CLICS. And amazingly, brilliant findings that we identified. So we found that the odds of an unplanned hospital admission was reduced by 17% for those who had received CLICS compared to those that had not received CLICS, up to 12 months after discharge from the service. And we also found that there were significant improvements in health-related quality of life and well-being, but it's important to note that this was without a control group. Next slide, please. Thank you. And then our second example here is PACT, is the Proactive Care Team. So this intervention provided proactive, holistic, short-term care and support for any vulnerable individual who was above the age of 18. Again, our aim was to use Connected Bradford to create that pseudo control group, and we were looking to compare data of unplanned hospital admissions and unplanned A&E visits for PACT and those who hadn't received PACT, i.e. non-PACT patients. And again, we found really striking findings. Here that we found the odds of an unplanned hospital admission was reduced by 31% for those who had received PACT, again, up to 12 months post-discharge from PACT service. And the odds of an A&E attendance was reduced by 41%, again, compared to those who had not received PACT. And we also found here as well a significant improvement in health-related quality of life. These two examples help to show the impact when there's a high need within RIC and an effective intervention. It can really identify that there can be striking findings, particularly not only for the individuals, but also for services, which can also have cost benefits as well. Thank you.
Thanks, Rachel. So then, I guess, thinking about sort of the journey as a whole, from starting from having sort of, you know, something based on good intentions to actually having demonstrated something that has potentially a really big impact on patients and services, it enables us to have a sort of an informed evidence-based decisioning that's like a home for life. It's really sort of a strong legacy and something that will last forever here within Bradford. And hopefully what we will start to see is that we have informed commissioning that's able to be based on the evidence, because we're providing implementation evaluations pretty much as standard across the board within RIC, and because we're starting to show evidence of promise in before and after studies, and actually because we're able now to look at really, really strong evidence through quasi-experimental studies, randomised controlled trials. So in an ideal world, I think from a researcher perspective, is we'd be kind of flipping this on its head and really sort of enabling and commissioning decisions that are based on a really well-informed evaluation. Oh, it's got this add-on things. And this is, you probably won't be able to see this, but I think Sophie's going to share the slides. But this is a summary from our final report, which shows how far we've come. So the first column here is what the level of evaluation evidence was in 2019 at the beginning of RIC. And the others are, sorry, the second column is the evaluation level when we were close to finishing RIC. So everything has been nudged up that scale, and as you've seen here, some have managed to go even beyond the implementation and actually get sort of some rigorous evaluation evidence as well. So it is possible. I think that with lots of challenges along the way, we've shown that you can do pragmatic, feasible and evidence-based intervention evaluation, which then can lead you to be really clear about what does and doesn't make a difference in reducing inequalities. And I think it's you know, it's been great working in partnership with RIC to do this, but I think it really shows that the strong partnerships is the way to be able to deliver on this. I'm going to pass back to Rachel to finish off this presentation.
Thank you, Josie. So we wanted to end with 3 points that we would share with others or other teams that are in a similar position. So as Josie mentioned earlier, we wholeheartedly encourage the use of logic models. We think that they're vital. So it's imperative that projects and interventions create a logic model, and not only that, they update their logic model frequently, because often logic models are created at the start of a project or an intervention, and actually people think that it's going to stay the same throughout the duration of the project, and that's not always true. So it's important to go back and refresh them when an element of a project changes. The second thing is it's important to work with projects during their study design phase to help them understand the importance of collecting as much suitable and necessary data as possible. It's important to get that balance between capturing as much data as you need without overburdening participants or patients, but it's important to try and capture all the data that you need as early as possible to make sure that you have everything that could be useful when evaluating. And lastly, it's important that you try and make sure projects are focusing on working towards long-term outcomes that are actually realistic and clearly defined. For example, if you state you wanted a long-term outcome was reducing obesity in under 10s, that's a lovely outcome, but it's very, very broad, and it's not clear how you're going to actually tackle that and how you're going to work towards that. So it's important that although you might have big aims, big goals, try and make sure that things are clearly defined, and kind of looping around a logic model will help you do that. I don't know whether there's anything you wanted to add there, Josie? No?
I think the only thing I would say is about, as well as collecting appropriate data, it's not collecting the stuff that you don't need. So trying to work through that and reduce burden where you can as well.
Yeah, thank you. So yeah, thank you. That brings us to the end of our presentation. Thank you very much for listening. If anyone's got any questions now, we'd be very happy to take your questions. And also just to mention, we have our final report, which is pictured there, but we've put a link to it there. So that this report summarises all the work that BIRU's done over the last 5 years. So if you're interested in understanding more and reading more, we'd recommend that you go there. But we're happy to take any questions now. Thank you very much.
Thanks very much, Rachel, and thanks, Josie, as well. That was fantastic, really in depth as well. Lots and lots covered, and lots of practical stuff as well. So questions have been coming in the chat. We'll be glad to know. I've got a few as well, but we'll do the ones in the chat. So if it's okay, I'll ask you those now. If anyone else has got any more, just put your hands up or put them in the chat. So first of all, there's a question from Helen Spate, which goes back to some of the statistics. So how did you calculate the odds for the clicked and packed findings? So any advice on how you do that sort of bit of the methodology?
Yeah, it's really complicated. Rachel and I are taking all the credit here today, but it's actually one of our researchers, Bo, who worked on this. But it's actually, it's kind of like it's a regression analysis, but what we did was something called difference in differences. So it's looking at the change in hospital admissions over time, and when you do a complex analysis, it gives you odds as the result. So really, it's just saying that the probability of ending up in hospital after you've had clicks is less than the probability if you hadn't had clicks. I don't know if that's helped explain it at all, but we can share the report with you, or we could talk it through in more detail if you want. Oh no, probably not me either.
Yeah. Thanks, Josie. And if you're looking to that, Helen, be prepared for some very long formula as well. Need to get your calculator out. Okay, thanks for that. So there was another question from Rachel Bannister, which was what do you think, what were the biggest challenges and hurdles that you found with working with the different projects for the evaluation?
I'll say one thing that's jumps out at me there. So we ran kind of drop-in sessions as well throughout over the past couple of years for projects to come with queries, questions. I think one of the difficult things was that they were all at such different levels to begin with, as Josie said, and some projects had got more understanding of certain elements, some hadn't, some had got very different documentation. For example, some knew what a logic model was and they came and they knew what they were aiming for. Some projects were a lot further behind as such in that respect. So I think it's been difficult trying to work, I suppose, to provide the tailored support that we need to for each particular project. I think was a challenge, but yeah, a good exciting challenge at that. I'll pass to Josie. I'm sure you've got some.
I think you're absolutely right there, Rachel. But I think another thing is, if you're kind of new to research and we're talking about kind of, there's a bit of anxiety sometimes about, I mean, obviously in these cases, we've got some incredible results. And I have to say, it's the first time I've ever worked on a research study that's had such a dramatic impact, honestly. But there is an anxiety that we might show that it's not working, and I think it's about working through that sort of, the value of that implementation is that you can tweak things as you're going, so you can make things work. So I think it's about getting that understanding and the relationships and understanding that we're friendly academics, I suppose, and we're here to do the best, not to try and catch people out. But I think sometimes it's just about that level of understanding and reassurance at the beginning.
Yeah, and there has been some real challenges with some of the RIC projects. If you start 20 projects off and then you've got a pandemic in the middle of it, things are bound to change, and not all of the original ones have made it through to 5 years. There was a smoking in pregnancy project, that there was some additional funding that came through the NHS, so that became part of core services anyway, and that changed. And then there was some of the other work that we just couldn't really get off the ground after a couple of years of trying. So you have to sort of admit defeat with some of them and come back later with a better model. So yeah, it is challenging. Okay, well, we've moved on. We've got another question here, and this is from Jennifer Emmel, and the question is, do you see a role for library services for evidence-based decision making?
I mean, I would say absolutely, yeah. I think that's a really good point, actually, because I think often there is evidence of what does work out there, but it's not being able to A, access it, or B, have the time to kind of summarise that. And I know that that's exactly what library services can offer to somebody who's planning to deliver something, is to go out and find out what is already out there that has got some evidence of effectiveness or evidence of implementation. And the other element of that, I suppose, is where I was talking there, the strongest evidence base is a systematic review, isn't it? And so if there's things out there that you're able to build on that and add to that learning, then yes.
Yeah, I think
if there's anything you want to add, Rachel.
No, nothing to add.
Yeah, I was going to say, I think that I mean, that's the for people that are connected to trusts or working in trusts, the library services and the resources that we've got in our trust locally are great, actually. I think sometimes we forget that they've all got their own libraries and they've got people that are really skilled in literature research and evidence-based and things like that. We're looking into it at the moment within the Reducing Inequalities Alliance to see, you know, what information we can spread around this so we can sort of maximise the use of those resources, because where you know, the NHS is under pressure at the moment, so we need to really sort of drive that evidence base. So that's a really good question. Thanks for that, Jennifer. So we've got a couple more questions in the chat. Let's just have a look through. Question from George Zito. Great presentations and data. Have you considered return on investment data on the reductions in hospital admissions? And I suppose this also applies to the welfare advice services as well.
Yeah, absolutely. I appreciate that. It is really important to do that. We kind of run out of time, is the honest truth, but it's something that we really know is very important. And I think at the moment we're doing a little bit more in-depth work around clicks and packs in particular, because we know that there is an effectiveness there, so that we can start to look at at least what the cost benefits might be. And we do have colleagues in York who do modelling work as well, so looking at longer term cost savings related to that. It is crucial, I think, because I think, you know, especially how challenging the world is at the moment in terms of finances and reducing budgets. You need to know that what you're implementing is cost effective as well as effective. So I guess it's kind of an apology that we didn't quite get that far by the end of this evaluation, but that it is something we're working on now and that is absolutely critical.
Yeah, thanks very much, Josie. Sorry, the questions keep on coming, so I'm gonna keep going on these. I think there's just a couple more now. So there's one from Carlton, who's asking, given many of the prevention focused initiatives should generate long-term impacts, have you planned to capture these? Or I suppose the question is, how would we capture these longer term?
I mean, I think that the beauty of Connected Bradford is that it's a resource that is there. I think it took us a long time, and I think actually it's another great outcome from Rick is that the data that's in Connected Bradford now is much more usable from GP and hospital admissions and the care trust where PACT was delivered. So there are always opportunities to go back there and look for longer term outcomes. And absolutely, you know, we know this time and time again, most of the big outcomes or most of the big greatest effects come way after the funding of the evaluation's been and gone, or things have moved on and changed. There isn't, you know, we don't have the same sort of capacity to continue the evaluations because it was part of that sort of 5-year RIC funding. But I think Connected Bradford is there, and I think we should always all remember that. And I think about if we're putting in for more funding for things, that maybe if you put in a little bit for the evaluation as well, then, you know, it is there to support this sort of work.
Thanks, Josie. There was a sort of follow-on question there around Connected Bradford, and whether there's any training on you know, just what's in Connected Bradford and how to access it, I suppose.
Yeah, I mean, it is the idea behind Connected Bradford is that it is or will become an open access resource. But I wouldn't dare do it without somebody who really knew about the data, because it is huge. There's anonymized data in there on every single person who's living in Bradford. So unless you really know what you're looking for and how to access it, it's not kind of like a user-friendly. I guess it's not like, you know, the fingertips that you can use online and just kind of look for a population. It's much more complex and much more in depth than that. So I think actually, if we're going to think about training, it might be on those sort of publicly open resources, because they're much more user-friendly and much more sort of useful. I think if you want to use Connected Bradford, you need to be thinking about having funding or resource for an analyst that can just go ahead and do all of that stuff for you.
Yeah, it's really complicated, isn't it? Okay, thanks for that. I mean, we'll send, just to let everybody know as well, we'll sort of send as much information as we've got out as well, to everybody that's dialing in for this call. There's a question from Marion Tweed Rycroft about the community readiness model. I don't know whether that's you or it might be, is it Shahid, Josie, and the team, but just wanting to know a little bit more about that, or whether there's a link and some further information.
Yeah, Rachel can talk about that.
Yeah, definitely. Yeah, thank you for your interest in that. Yeah, there's definitely something. If you want to, so we've done papers on, we've done a paper on our work that I briefly mentioned earlier. But if not, I can always send you links to resources that explain a bit more about the model. So please feel free to get in touch. My email address, I can put it in the chat, but it will be at the end of the slides that we will make sure we pass on to Sophie to send round.
Yeah, and I think it's been used quite a few times in Bradford as well, hasn't it? So obviously we've done it with Rick, we did it with the Better Start work, but I think Zara's done some work on community readiness as well. I think there's pockets of it being done, so I think probably ought to think about a community of community readiness people who are interested in that. It is really valuable, I think. It really does, because it's not just telling you where it is, it kind of demonstrates how you can improve readiness and get people to move up that, and that's the real value of it, I think.
Yes, Zara Niazi, who's the she's a joint post between the NHS and the council, and leads the Equality, Diversity and Belonging programme. So she's got lots of stuff on this, on community readiness. So if you know Zara, get in touch with Zara, or if you want to just get in touch with me or anyone in the inequalities team, we can put you in the right place there. Okay, so there's one final question. Thanks, Rachel and Josie, for answering all these. It's quite a difficult one to answer, but it's probably a good one to end on. It's from Chris Bolson. So, having listened to some very interesting, informative presentations and about the evidence base throughout the week, what is the impact of all this combined on the overall RIC objective of reducing healthy years of life gap, or what do we expect to see in terms of the impact? Do you want to have a go at that, Josie?
I was just thinking then, shall I just pretend to freeze and then I don't have to answer that? I mean, I think there's so much, and I think there's something about, we were talking about this at the final sort of RIC meeting, weren't we? But it's something about, it's not the individual interventions, and it's I mean, it is, because all of these things have been important, all of these individual pieces of work, but actually when you think about it as a system and how it has influenced and changed things and changed how people are thinking about the work that they do and the things that have come from it, like the Reducing Inequalities Alliance that sort of fed from this, as a system, as a big, big drive, it's made a massive impact. And I think trying to capture that as we come to the end of RIC is going to be really important. And I think as Rachel said, we've pulled together a report of what we've done and what we've learned from the evidence. But I think it's about trying to sort of get that broad overview of that impact. And at that point, I'm hoping that Sahail's got something profound to summarize that with.
Yeah. Okay, thanks, Josie. It's a difficult one. I mean, in combination, the RIC services have reached 16,000 people by our records over the last 5 years. So it's a pretty big chunk of the central Bradford population. It's difficult looking at the overall impact. I think that particularly the work that Josie and Rachel and team have done shows definite improvements in specific cohorts. Reductions in implant hospital admissions and things like that. It's very, very complex when you look at a whole population of 150,000 and the impact on that.
Yeah.
Okay, so
actually, can I just one more point on that as well, because I think it kind of goes back to what Carlton was saying earlier. I think you should never expect to kind of see a reduction in healthy years of life in a short period of time, and I think this is part and parcel a problem of these sort of commissioning cycles, because it could take a whole new generation for all of this to have an impact and move forwards. And I think it's something about, again, it's about having that sort of like commitment and system that does this, and that continuing at the evaluation that enables you to see the slow change over time rather than expecting something big and sudden, I suppose.
Yeah. Okay, thanks, Josie. Right, so we've just got one more thing to do before I wrap up. I just want to hand over now to Dr. Sahel Abbas, who's been leading the RIC programme right from the start with us and the rest of the team, and with Josie and Rachel and so on, just to say a few words before we close up. So over to you, Sahel.
Thank you very much. I didn't know what to say today. I mean, it has been a really good week. I mean, listening to the impact of the program that we all developed, and listening to the impact of projects on real people, it's amazing. I think in terms of RIC, obviously it has been a flagship project of health inequalities in Bradford District and Craven for many years. It has been our flagship project. As Duncan said, more than 16,000 people have benefited from the projects and the program. We have heard about the quantitative, 31% reduction, 41% reduction is brilliant. As Josie said, usually these sort of interventions at the end we say it might have worked. We really don't know, but this is really statistically significant improvements. But as a clinician working in inner city, I've also seen and used these services on individual patients. So I can actually say, how much impact these projects had on the lives of real people living in really deprived areas of Bradford, inner city Bradford. So we shouldn't forget that it's quantity and quality. Obviously, we have shared with you, we started this project 2019 created on the principles of equity and proportionate universalism, giving more resources to areas of deprivation, use population health management approach, all of that. And about more than 50 different organizations have worked together in creating and implementing the project. And we have done a lot of new things, a lot of innovative things, a lot of new ways of working. Bradford Inequalities Research Unit, the one of the first projects, if we say, was developed as part of RIC before we developed anything else. And it has been amazing. This program and the projects have attracted regional, national interest. We know, a lot of integrated care systems are coming to us, to project leads, program leads, and we are constantly now presenting how we developed this program. And I think it took about 12 months to develop from an idea to the final. It was a lot of work behind that, but we have all that now. We have all that. When we started, as Josie said, we didn't know that. When we did the literature search, we didn't know what will work. We just went with this life course approach and did the best with the evidence available then. And now, as Josie has shared, at least we know that these projects, these programs are work, and we can incorporate that learning into the next into any next program that we do. But I think what Chris said is quite right. I think what we are, and this is a journey for me as well, in as in commissioning and as part of ICP leadership. These programs, and we have done RIC. We also did universal healthcare program last year, and the main learning from universal healthcare was that the way we design and deliver our services, we just bake in inequalities. So we have to change the way we design and deliver our services. We really want to have a difference, to make a difference. So all these programs, RIC, now Core 20, now universal healthcare, I think the fundamental issue is we take these as an end in itself. These are the means to a final end, which is how do we use the totality of our resource? And whatever we have done in RIC is has given us a lot of tools and a lot of evidence to show what works, and to show that a lot of these things we can do without this extra funding now. Proactive care team, for example, who is stopping us to configure our community teams as the proactive care team? Who is stopping us from using the, social prescribers are now part of our primary care networks? What is stopping us from using this learning to do that? So yes, these sort of programs will continue to make the case for more resources into the areas of need, but also will continue to build the evidence base of what works. And today, when the RIC is coming to an end as a program, although the legacy of the RIC program and also its projects, many of those will be as business as usual, but the inequalities are not coming to an end. So they are persisting and actually worsening. So living in these post-COVID, post-pandemic time, where societal inequalities are worsening, as well as our severe financial, real financial constraints on our statutory services, I think what we cannot do is to lose focus within all these difficulties, lose focus on health inequalities. And for that, all of us are responsible. So we are collectively responsible to hold ourselves to account, hold our peers to account, hold our leadership to account, to continue that focus on health inequalities. And for that, for that, as Josie said, we have developed this Reducing Inequalities Alliance in Bradford District and Craven to take that collective action. So we'll be sending out all the links to these 4 workshops. We will also be sending out the RIC final report, and we're sending out the links to the Reducing Inequalities Alliance as well. So I will urge everyone, encourage everyone to be part of the alliance and be part of the movement, because we are the conscience of our system. We can do it, but we can't do it alone. So let's do it together. And finally, really want to say a huge thank you to everyone who worked in RIC for the past many years. The passion, the enthusiasm, the hard work, the love for the people living in the most deprived areas in Bradford. That was amazing. And so thank you very much. Thank you.
Thank you, Sahel. That was great. And I think we'll leave it there. For me, I always thought you can, inequalities unfortunately are stark, but I think what we've learned is about the individual contribution that services and people can make. And I was just trying to think about 3 things. I think about the 3 A's model, which is so simple that even I can remember it, which is what is your awareness of the inequality in the area you work? What is the action you can take? And what is your advocacy role? Tell somebody else about it. Tell them about the work that you're doing, what works, what doesn't work. If you just remember those 3 things, we can all make our difference. So that's it. The only bit of homework we'd say is have a look at the overall report when Sophie sends that around to you, because whatever area of health you'll work in, you'll find an example, something there that really resonates you. It's got the detail of all the different 20 projects in there and what they found and what they didn't found, with some overall conclusions. So thanks very much to Josie and Rachel again. Hopefully we'll speak to you all soon. Collectively, we just need to keep this RIC learning going, don't we? So have a good rest of the week and speak to you all soon, hopefully. Okay, bye.
Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.